slides. And whenever you're ready, Reid, over to you.
Perfect. Can you hear me okay?
I can hear you beautifully.
Awesome. Sorry, I'm not super familiar with Teams, so I will.
Next to your leave button is a little up arrow that says share. So don't leave, just share.
Yes. Okay, can you see my screen?
I can see them beautifully, thank you.
Okay, and you can see just my slides. Okay, well, thank you everyone so much for your time, and thank you, Joe, for giving me an opportunity to take some of your time to talk about my experience as a research fellow. So for those who don't know me, my name is Reid. I recently graduated from MIT with a degree in biological engineering, and for the past 10 weeks have been doing a research fellowship with the Global Surgery Division. So I will quickly recap some of my experiences. So I've divided my presentation into the 4 pillars of global surgery, starting with advocacy. So I had the incredible privilege of seeing the advocacy team in action in Google 2, presenting a recap of a cancer workshop that they had run previously. So this workshop talked about breast cancer, cervical cancer, and prostate cancer, and emphasized the risk factors, screening options, and treatments, as well as symptoms to look for at the patient level to advocate for community members seeking care. So here are some images from the training materials from that workshop. So the goal of the workshop that I was able to attend was to see how the community health workers and health forum leaders had incorporated this information into their own work, and what would still be helpful for community health workers to know in order to make a larger difference in their communities. So time was given for the community health workers to work together and write down everything that they had remembered from the previous workshop, how they'd currently been using the information, and what the existing barriers were to furthering the community's understanding of when to seek care, what barriers were in the way of patients going to the primary care level, etc. And so this ties nicely into the research portion. So some stats that you are all very familiar with: 30% of the global disease burden is surgical, and 5 billion people lack access to safe and affordable surgical care. Addressing the delay in patients seeking care, or the first delay, is critical to reducing the surgical burden and improving patient outcomes in low and middle income countries. So some of the existing barriers to early cancer diagnosis that have been identified include patient lack of knowledge of disease symptoms, disconnect from health systems, as well as a fear of diagnosis and treatment. So again, if patients are unaware of when they need to seek care, they don't know how to seek care, or it's their physical barriers or systematic barriers, as well as fear of being sort of exiled, or not understanding that if you have a cancer diagnosis, that doesn't mean that you're going to die, or that your community will not accept you. And one solution are community health workers who have an existing relationship with the community and specialize in health promotion and education. So this is a project that I worked on setting up with Barbara and Salome. So if you have any questions about it, please refer to them. So the study is a mixed method survey of community health workers after a global surgery run workshop, which will test how often community health workers use knowledge presented in the cancer workshop, as well as gauge their perceived motivation and importance to offer these health promotion interventions. And the overall goals of the project are to understand how to strengthen these trainings for community health workers, measure the impact of the workshops on community health worker behavior, as well as their attitude towards the workshop, and address a critical research question of how to better advocate for training curriculums for community health workers, as well as continued education programs and develop better professional development opportunities in general. And based on my literature review and time spent with the Global Surgery Division, some suggested future research areas in the space of community health worker training include thinking about how to most effectively how to empower community health workers to most effectively make change through health promotion. So incorporating some behavior change theory into the community health worker curriculum, as well as investigate if case study and simulation-based training for community health workers is more effective in knowledge retention and efficacy as opposed to a lecture-based style, and building capacity for community health workers to offer mental health promotion and education in the Western Cape. So I also had an opportunity to see a lot of education and global surgery awareness initiatives. So Salome gave lots of incredible presentations to medical students, physicians, and academics, like her inaugural. I also got to be a part of the Global Surgery Hackathon, which was organized by Xander from the Surgical Society, which introduced a lot of medical students and health science trainees to global surgery. Further, I got to attend the executive leadership course closing ceremony, and it was amazing to see what work can be done in such a short period of time when physicians were given support to conduct a research project or try a new implementation strategy. And it really brought to my attention the importance of leadership training for physicians, because there are so many systems and teams in medicine, but not a lot of emphasis on how to best lead and organize a team. And finally, next week, I will be attending the Global Surgery Foundations course, which I'm very excited about, and is run by the division. And then the last pillar, implementation. Salome and I yesterday got back from Limpopo at the Tabazimbi Hospital for a Rural Health Matters Obstetrics and Gynae event. This was a really great experience for me to see what a rural hospital in Limpopo looks like, as well as witness the skills sharing that happens through the implementation program, or that's similar to what the global surgery implementation programs do. I also got to see some new tools be explained to physicians and nurses. So the picture in the middle is a bag that captures blood during birth so that medical teams can quantify blood loss. So also just seeing how a really simple solution can make a huge difference in patients' lives and families' lives. And then I will quickly talk about some of the other experiences that I had as a part of the Global Surgery Division. So we met Oprah. This video was captured by Jackie. So we went to a trauma-informed education workshop sponsored by the Oprah Winfrey Leadership Academy for Girls, which was really informative on how to have better informed education, not only for students, but also in medical field. I got to observe theater, so thank you, Lebo, for letting me shadow you. And then Jo let us sit in on her ICU class. It was really interesting for me to see how medical training is done. So seeing a combination of simulation work and lecture-based learning. And I thought a lot about what is incorporated into a medical curriculum, but never how this is implemented. So it was very interesting for me to see. And so my key takeaways are the importance of medical leadership training, having strategic and measurable implementation, building community and relationships in the medical field and public health fields, as well as strengthening systems sustainably by empowering various stakeholders to take action. So thank you all so much for your time. Thank you to the Global Surgery Division for having me. It's been a really great experience, and I am excited to keep in touch and keep working on some of these projects. So thank you again all for your time.
Thanks, Reid. It's been such a joy to have you, and it was a really wonderful presentation. Thank you so much. I don't know if anyone has a question for Reid while I just get my PowerPoint up and rolling.
So not a question, just a comment, just to say it's been wonderful having you, Reid, here for the past 3 months. And yeah, really excellent work that you've done, excellent summary of what you've experienced whilst you're here. And so, yeah, we will miss you from the division, and yeah, hope to keep, working with you, or you remaining part of our network after this. Thanks.
That's the official
so
Salome, don't be a stranger instruction. Thanks, Salome, and thank you so much, Reid. And without much ado, I'm going to start my presentation because I'd love to leave some time at the end for questions and discussion. So I want to talk about global surgery in action and some of the frameworks that we've developed, and a little dig in at the end and into some evaluation frameworks, because I think that that's kind of one of the most exciting things that we can do for our programs, but also to understand what kind of evaluation is possible. We know what we're up against in improving perioperative care in Africa. We know that we have twice the global average in terms of mortality. We know that our complication rate is very high, up to 1 in 5 patients, that we don't have the resources of well-resourced settings, that instead of the 20 specialists per 100,000, which is the recommendation, we're sitting at around 0.7 on our continent, and that most of our surgery is urgent or emergent surgical care. And so what I want to do is frame global surgery in action in the 4 pillars of global surgery. And so while we are really talking about the implementation cluster, it's intertwined with research, education, and advocacy. So I'm going to unravel a little bit and show you what it looks like on its own, but it really is nested within the larger pillar grouping. Advocacy was introduced to us beautifully by Reid this afternoon, and nothing about us without us. One of the big gaps in the way that healthcare is conducted is with not enough voice from the community and from those to whom we provide our healthcare. So advocacy, implementation, these things are well intertwined, and we as Global Surgery in Action practitioners and groups need to know that our programs are rooted within the community and are well established as their desires, and that we have buy-in. And we're going to talk a little bit about research towards the end, but I just wanted to tie in and say research is a really important part of program introduction and evaluation. And often when we are planning our interventions, our programs, our global surgery in action work, what we need to do is have a look at the data and ask what exists and what we can use to build on, but also what data do we still need? What is the unmet need in that area? And I think that one of the things that you've heard from the global surgery education team and the global surgery implementation team a lot is we have guidelines. There are global guidelines that kind of tell us what best evidence is for care. But how do we adapt existing evidence and those guidelines to low resource settings? And very excitingly, the European Resus Council came out this week stating that they were going to be moving towards guidelines for resuscitation in low resource settings. And I think that the global conversation is really starting to talk more about context and how we can't paint healthcare with one single brushstroke. And then a really important and very exciting to me part of the research that I'm seeing come more and more forward, but also something that we need to advocate more, is the patient voice within the work that we're doing. Capacity building work. What is the perception of the community and the patient in the work that we're planning, and how we think we can conduct our clinical care and our perioperative strategies in a different way. So how do they perceive it? How do they receive it? These things are really important, and this is how we conduct patient-centered care as well. As part of this, the Global Surgery Division has developed a research framework, and it's a really exciting way of describing how we plan to implement different research strategies and how these things all tie in together. But what I want to highlight here is the pillars on either side, because they tie in well with the implementation framework that I'm going to show you in a second. So on the demand side, we know that access and uptake of surgical care is difficult and a huge challenge in perioperative care across our continent. We know that accessing care and accessing care timeously is an important part of how we evaluate a healthcare system. And on the other side is the supply side. So how do we supply quality perioperative care and surgery? How do we ensure good outcomes and best outcomes for patients and their families? So on to what we really want to talk about, which is implementation, tying into the Global Surgery in Action framework. And what is implementation? A thing that's kind of difficult to define, and something that we get asked about quite often is, so how is implementation different from advocacy, and how is it different from research? And the answer is that these things all form part of implementation, but I view implementation in some ways as putting policy and research into practice. So how do we take best evidence? How do we take policies which can improve care and ensure that that's what's happening at the patient bedside? And of course, there's an education element to that as well. But what we want to emphasize is that it's all about context and relationships, multidisciplinary teams, ethical practice, and buy-in. The literature around these projects, the literature around sustained healthcare worker behavior change is rooted in context-specific interventions which focus on interventions and training, which is developed by the team on the ground at the coalface. They dictate what it is they need, and that's how we see the best sustainable change and the best translation of knowledge into practice. And that's what we're doing after all. We're harnessing human potential through both a person and patient-centered approach. So we want to make sure that the healthcare we're providing is friendly for humans and is what they want and what they need. But most importantly, these programs are not useful unless we have the data to inform them, and we also have the planned impact measurements from the beginning. And we're going to talk about the model for improvement in a second, but developing, piloting, and scaling is the aim of most programs. So we want to develop a program in a collaborative way. We want to pilot it and see what we can learn, and then see how that program can be scaled. And we'll talk about some quality improvement methodology in a moment. So the impact priorities for Global Surgery in Action have 3 parts: improving access, improving quality, and reducing the need for surgery. We think that if we can increase the quantity and the cost effectiveness of surgical care, that if we can decrease delays to surgery and increase the quality of surgery, and if we can reduce the need for surgery, that these are important parts of improving access to quality, safe, and timely surgery for those who need it the most. And so here it is, the Global Surgery in Action framework, where we aim to strengthen systems, services, and leadership. So the problem statement, as you've heard, is 1 billion people in Africa lack safe and timely access to surgery. And so we think that the process, which mirrors the IHI model for improvement, which we'll talk about in a moment, is to diagnose, co-design, act, evaluate, and continue the cycle of diagnosis, co-designing, acting, and evaluating, with a vision to keep moving towards a world in which all people have access to quality, comprehensive surgical care. So what does diagnosing mean? It means that we take some time to review the data we have available and ask ourselves what data we still need to move forward in an informed way. That we spend time in that diagnosis phase really engaging stakeholders and stakeholders in the broadest sense of the term. So those who will be enacting the work, those who will be receiving the consequences of that work. We want to talk to leadership. We want to talk to those who are at the coalface, but also to the patients in the community. And those are the same stakeholders that we would hope to engage in our co-design phase. And co-design is an important use of phrase, which you may not see in other model of improvement kind of work, or it's something that we really, really want to emphasize during our work, that for the Global Surgery Division, this is a partnership. This is us enabling others to do the work that is theirs and not necessarily coming in and dictating, which we think is a recipe for disaster rather than a recipe for success. Our next part of the cycle is to act. And by acting, we mean that we're trying to implement the work that we want to do, but that we understand that the acting is part of the learning. So we're going to evaluate what we've done, and we're going to see what we would do differently and keep going around in that cycle. Wonderful. So this is an exciting development for our division, and we're very, very pleased to present this Global Surgery in Action framework. This is the Institute for Healthcare Improvement, or IHI model for improvement. And it's an internationally based standard model for quality improvement in healthcare in particular. And if you aren't familiar with some of the quality improvement methodologies, I really recommend visiting the website, which is in the bottom of your screen. There's lots of free courses that you can do. There's lots of case studies that you can read. And the IHI really are just the absolute world leaders in helping people learn how to improve their systems and giving you the tools to improve the system where you are. Our advice to you, if you are going to follow any kind of program, is to not lose hope and to make sure that you're planning, doing, studying, and acting phases, which mirror the cycle that you saw in our own framework. Don't get discouraged. These things can feel like you're losing your way, but just remember that all you're doing is learning, and that it's meant to be an iterative process, that you're meant to go around the cycle multiple times. Wonderful. So steaming towards how this all ties in, we know that education is likely to be part of any form of Global Surgery in Action program. There may be an educational element to it, and a lot of capacity building definitely has to be the focus of reaching our impact aims. So how do we make sure that we have quality surgery and more surgery? Well, we need to build capacity within our healthcare services to open to offer these services. I have a huge simulation-based education bias, because I think that that's really how we teach better, and how we can translate knowledge into practice in a way which is safe for patients. And I've presented about it before, so I'll restrain myself. But just to emphasize that simulation is not only about knowledge, it's also about systems testing and quality improvement and helping teams work better together. So there's a huge and really exciting movement towards simulation-based education on our continent. And if you haven't checked out the African Simulation Network, I highly recommend joining us. The other challenge in education that we have on our continent in perioperative care is fellowships and specialization, and how can we make specialization training more sustainable and easily kind of transferable. One of the questions in capacity building is around task shifting. So non-surgical specialists performing obstetric, surgical, and anesthesia care. And what we need is a lot more research around what's the perceptions of these interventions. So I'm going to pause for a second and let you scan what I have on my screen here. And I'm going to give some kudos to the teams at King's College London, who have done a beautiful, beautiful job of producing a program evaluation piece of work that we're gonna go through now. So evaluation of programs is a really important part of our implementation work. And the reason I want to emphasize this toolbox in particular is I think it explains it in a really beautiful way that you can grasp. So I'm going to go through it quite quickly so that we can talk about it. So when we evaluate programs, we can evaluate programs as a black box. So we only want to see the effects. We don't want to evaluate too much about the components, but if we put in X, does Y happen? Very straightforward, not a lot of complexity, black box evaluation. Perhaps we would like to know a little bit more about the components of the program, and we may want to know how some of the context influenced the program, but we don't know too much about the inner workings, so we would call this gray box evaluation. But if we have a small scale intervention where we could really dig down into why an evaluation worked, how it worked, the contextual factors, how all the components of our intervention really integrated with the system, and we would look at clear box evaluation. I'll illuminate this for you in a second. And just to note that I'll give you the QR code again. There it is on the bottom of your screen. But the workbook that you can get from the QR code, and I'll email it out after the session, has a really beautiful way of explaining this. So black box, we are asking, does it work? Gray box, we're asking, does it work? And I, sort of starting to wonder, why do people think that our program works? But with clear box thinking, we're asking, what works, for whom, in what respects, to what extent, and is it contextual, and how does that affect everything? So you can see the kind of spectrum that we're following here. And here, this is where we're going to tie back into our research and our education principles and pillars. So if we're looking at black box thinking, we're just looking at really quantitative data. So we want some surveys, and we're probably going to try and demonstrate some statistical changes. If we're looking at gray box, we are moving towards the mixed methods. So we're going to get some quantitative data, but we might also ask some illuminating questions, like why do people think that our intervention helped them do X better? So we're moving towards mixed method. When we're in the gray, in the see-through box, so we're not eliminating that we could have some quantitative overarching evaluation. But when we're really digging into the program, that's when we're going to be asking the qualitative questions. And remembering that good qualitative work is us comparing experiences to a framework or comparing experiences to a theory. And so we would really want to check in on how to investigate those experiences as compared to X. Wonderful. So getting towards the end, black box, does it work? Gray box, does it work? Why do people think it works? See-through box, we're getting all the way in there. We want to examine all the components, all the contexts, and for whom we think that this is the most successful. And I'm going to pause for a moment and talk about Kirkpatrick frameworks, just in case you haven't seen them before. So this is the most widely used model for how we interrogate training and education programs. And just to be clear that these levels are in no way hierarchical. So a lot of the work that we see, the survey post-training, will be level 1, level 2. So how did you feel? Do you feel engaged? Were you able to, was it what you expected? Level 1, feelings, emotions, reactions. Level 2, learning. Now, knowledge, skills, attitude, confidence. These are the most commonly used evaluation markers for any kind of education work. Now, what these things will show us is that in that moment, what knowledge, skills, attitudes, and confidences did that person have? But just a reminder that evaluation and true success and sustainability means that knowledge, behavior, practices, change in clinical care must be evaluated at multiple time points. And that's part of why I wanted to talk about this framework is in the moment, directly post-training, there's nothing wrong with asking some knowledge questions before and after, or even just after if you don't have the luxury of before. So we can measure a knowledge translation there, or sorry, a knowledge gain there. When we move on to behavior and results, these are the things that are much more tricky. This is when we're starting to talk more gray box and illuminated box thinking. So we would be, for behavior, we would perhaps be observing and asking illuminating questions and doing some qualitative work around that. We may be, for level 4, this is where we would really start to dig into our kind of QI questions and moving towards how our programs are working to improve patient care at the bedside or in a larger scale. And for now, I'm going to stop. I think I've given a bit of a teaser as to what is available. And I'm going to stop sharing my screen so I can stop sharing my screen so I can see some faces and ask if you have any questions. All right, no questions. Does anyone have a program that they're considering evaluating that they'd like to talk about? Barbara.
Hi, everyone. Thanks so much, Joe, for that presentation, and Reid as well for your presentation as well. What I would like to ask, and it's a question, it's not me saying I've got a program that I want to discuss, but I think it is important for us to be able to measure appropriately. And I think we've done quite a few trainings already, and the way we've structured our evaluation and the way we are preparing to structure our evaluation, I think needs to be informed by exactly this process that you've underlined. Is there a way that we can set up some kind of support system within the team that allows us to implement from the beginning? Because I think it's important for us to have it in place before we start the next program.
Yeah, so I mean, the first thing would be, there was maybe one slide that I will show you from, which is slightly different, and just to illuminate the difference between research and program evaluation. So I think that if we consider research and evaluation, research is planned, systematic, rigorous, and analytical, and so is evaluation until we get to the next part of it. And I think that this is a decision that we make at the beginning of when we undertake planning even of a program. So a decision early in our programs about whether or not it's research or just plain evaluation. And if it is research, then obviously there's a process to get that ethically approved so that we can use that data. But evaluation may not always be public or visible, and we may just be focusing on our process improvement or impact. So I just wanted to emphasize that that's, we may be making sure that we meet our goals, but if we were doing research, it would be to disseminate our findings and making sure that we are able to help other people copy our program. So I totally agree with you that there should be strong work done before we embark on a program as to who our audience is. And when you go through the workbook, you'll see that there's also differing degrees of program evaluation. So we ask ourselves things like, how much capacity do we have? How much data is available to us already? And so absolutely, Barbara, I agree. And perhaps those of us who are embarking on these projects should be going through the workbook together before we start implementing. Thank you for your comment. And I see that you're doing some program evaluation already, which is really, really exciting. Slomi, you definitely don't have to put your hand up. You're the boss.
Thanks, Joe, and thanks for the great presentation. I think I just wanted to add on what you've just said or what Barbara was saying, because even the stages, I believe, of evaluation, and initially it might just be measuring, did they, have their knowledge or skills acquired and all of that, but over a 6-month period, did they retain it? Did they use it?
Mm-hmm.
And ultimately, after a few years, maybe you can see a reduction or an improvement in outcomes. So I think, as you're saying, planning it in advance and kind of clearly stating what is the long-term impact and short-term impact, and then planning it into that. Yeah, thanks.
Thanks. And I think that's a really valid comment, because when I read capacity building literature, when I read educational literature, so much of it has very poor evaluation built in. And so it's very hard from the outside to read someone's work and know how to replicate it, but also know the impact of their work and how it's been sustained in the clinical setting. And I think that was quite shocking to me. Yeah.
And I mean, again, I think I completely agree with you, because what people do is, we tend to want to be the heroes. And so what we describe as impact is simply doing the course or running an initiative, and then writing how excellent we are. And that is problematic, I think, in global health circles, and also not doing comparative studies where you could show, in a community where this intervention was done compared to where it wasn't done, and then what is what's the difference and the outcomes. So I think there's great opportunities for us in global surgery to really go into impact evaluation. Thanks.
Thanks, Lomi. Barbara and then Mary.
Thanks, Joe. I think one of the areas that I'd like to ask about is NQF levels. And so the area that I'm working in particularly is for community health workers. And if we look at the criteria or the entrance level for any kind of training that they're doing, there is no NQF level. And so part of the decisions that we have to make at Global Surgery as well, which I would raise here, is should we be deciding on NQF levels as well as an entrance criteria, because that's also one of the questions that are being asked of the UCT short course application forms that we're filling in. And as we've done some of the evaluations, well, we haven't done them in depth, but I think what's emerging is the need for us to understand who our audience is. And so that's my question, is how do we decide on that? And should we be considering NQF levels when we're doing the short courses? Thanks.
So I think that's a great question. And as a runner of short courses, short courses are a tricky thing. So I think that the conversation I would bring in here would be about micro-credentialing. So micro-credentialing, just as a broad definition, is the use of small interactive or just small educational courses or experiences that you allow to build up towards some form of qualification. And that's really one of the priorities of UCT, is to move towards the kind of better access to education instead of having to. So, for example, there are courses run in our faculty where you couldn't work full time while doing that postgrad, and that can be a barrier for people across our continent, across our country, who can work unpaid for a year. And so I think that this is that's the direction that I would drive that conversation in, towards multiple short courses which are micro-credential towards something larger. And I think that the NQF question in most short courses can be ignored, if I'm honest, because it's not, unless it's building towards a degree in an NQF level. So as an example, one of the biggest simulation master's programs in the world in surgical simulation is run in Australia. And in those situations, you can either you can do the short course as a standalone, or you can do the short course and the assignments and the mini thesis and get a master's degree. And so that's the kind of micro-credentialing that I'm talking about. Did that answer your question?
Can I just add, Joe? And all I just want, I mean, like, there is a conflict, for example, for myself as director of education, you know, my thing is like, add NQF to everything and get everything accredited. But what we must remember about these is they're really about capacity building, and it's really to from an implementation and a community health education perspective. And so I think it needs to be sort of individualized. As a university, the benefit, or one of our benefits, is that people come to us because they want accredited courses and things they can put on their CV. And when we create that opportunity, it's kind of a win-win situation. But these are not kind of our core education products, and so we should also balance that at the end of the day, it's teaching that we're trying to do to increase capacity, to improve outcomes. And if accreditation is not necessarily relevant, or if it's going to stop the process, then perhaps we should be less stringent on ourselves. So I think it's just balancing the real benefits of both as we decide on each course individually.
Yeah, I mean, my faculty development short course is not, it doesn't have an NQF accreditation on it. It's just a standalone short course. Mary, take us away.
Hi, everyone. I'm going to change course in the conversation, if that's okay. I really thank you so much for this presentation, and Reid, thanks for yours. It was really helpful to have an overview of what you've been doing. And Joe, I really liked the black, gray, and white box approach. And I think this notion of kind of more positivist and then, you know, constructivist other side is really valuable to think about evaluation from all these different angles, and, you know, the pragmatic in the middle. One of the things I do think is an opportunity with global surgery, is because it's a new frontier, if you will, is finding ways to share lessons learned pretty rapidly. And I think that's going to be really important, particularly as more programs are being rolled out. And I think, you know, we can talk about evaluation, you know, planning it at the start of the program as a way to have continuous learning throughout. But also finding ways to disseminate that. I think the knowledge translation component is really critical. And I would encourage us to not try to just show the shining examples, but also the lessons learned, the failures, as you know, people are afraid often of sharing those failures. But I think because it is so cutting edge, we do need to, I think, kind of more rapidly get out lessons learned as we're learning them. And find ways to distribute. And I think as a, you know, building a kind of a center of excellence, if you will, around global surgery, thinking around ways in which we can do that. And I think, you know, Barbara, your question about audience is really important, and something that we should probably step back from and ask ourselves, who is the audience that we're trying to target with lessons learned around program evaluation? You know, is it donors? Is it people in the field? Is it global? Is it, you know, in country, et cetera? And that will help then shape whatever format. But my experience is having some sort of system in place as like a division to document in a systematic way the program learning and sharing it, like even like a 2-pager template that you produce, around the different phases of the value of the program, for example, that helps you to then just get it out as it's part of the program. So just wanted to throw out those thoughts that were coming through. Thanks.
Thanks. I'll put it on my to-do list, Mary. Thanks. Yeah, I think one of the things that I found most interesting, so one of the projects that we're doing as Global Surgery in Action is trying to help a rural district hospital improve their surgical offerings. And as step one, the first thing that's being done is a piece of qualitative work, asking those who work in the hospital their perceptions of surgical capacity building. What do they think is possible? What do they think are the priorities? And we really have been quite surprised by what came out. A group of anesthetists went in offering them some kind of like anesthetic capacity building, and they went, no, we actually think we're okay at anesthesia. And the anesthetists were like, what are you talking about? So I think that this is also we actually, until we're situating our programs within the communities that we're working with, and I use the word community very broadly. The community could be, rural healthcare sites, facilities, systems are a community. They are a very personal experience for healthcare workers and for patients. And, I think that that's an important consideration. So thanks for your question. You're right. And I think the kind of assessment part of how we get to establishing a Global Surgery in Action project also needs some kind of framework around how we and this is what the framework is for, talking about co-designing, talking about planning. I'm up for one more question if anyone has one. Otherwise, I think that Reid has prepared some interpretive dance for us. All right. If there's no more questions, then I'm going to send you a beautiful, masterful, systematic review, which is about behavior change in healthcare workers, which looks at how do we affect education in a way that helps people change the way they behave day to day. And it really focuses on co-designing and co-creating programs. And then I'll send you the workbook and the open access resource around program evaluation, which will help you to plan your program evaluation. And it's something that you can do easily by yourself. Thank you for the opportunity to present today. And we look forward to months and months ahead of 2023, only a handful of months of learning together on these Friday afternoons. So thank you very much for joining, and we'll see you next month.
Thank you.
Thanks. Bye.
Thank you.
Thank you, Joe.
Thanks, Joe. That was a great presentation.
Thanks, Barbara. It's always lovely to hear your perspective, and I was very excited to see your work.